thank you very much for this introduction, and thank you very much for inviting me to this beautiful city and beautiful country. I come from the far north. I arrived yesterday. It had been frost during the night, and it was 2 degrees Celsius when I left for the airport in the morning. It was 22 when I landed here, so some difference, but I did remember to bring different clothes though. So my task here, and I really have to apologize that my Greek is so bad that I speak in English. My task here has been to speak on overuse of thyroid hormone therapy. And well, this is directed mainly towards clinicians, of course. Now I will make an introduction and then go through what are the risk factors for overdosing actually in the milder cases of hypothyroidism. Do we have to correct if we have mild iatrogenic hypothyroidism? I'll really come back to this, of course, later. And then conclusions. Now, this is a field that is attracting more and more interest, especially since patients seem to disagree very much with endocrinologists concerning thyroid hormone replacement therapy. They tend to want to be slightly overdosed, or at least having more T3 than T4, and go for combination therapy, and are really putting endocrinologists on the spot. If you heard the excellent lecture this morning of Grigoris Efraimidis, who is in my department, but your countryman, he talked on this paradigm shift in treatment, so I will not, of course, go into details on that. Now, when does overuse normally take place? Because, of course, it's not something we as clinicians do deliberately. There are some patients still who intentionally take it for weight loss. We had that as a very big problem before the synthesized T4, when we only had desiccated thyroid. All patients were overtreated. We have no means of controlling it because we couldn't measure TSH sensitively enough. So we knew they were all overtreated, and we really found it a very big advantage that we were able to get the patients euthyroid with the new TSH methods, who were able to put the correct treatment in response to the correct measurements. But now they seem to be going back, and still some patients want to, it seems that gaining weight is one of the less socially acceptable things in the modern world. So, of course, we do sometimes use suppressive therapy intentionally for thyroid cancer, but if we continue when the patient is at low risk, that is to be considered overuse. It could be accidentally by wrong dosing. I've come across a case report that presented a patient put on T3 actually, but instead of 25 micrograms, the pharmaceutical company had put in 25 milligrams. So that is, of course, an accidental wrong dosing. And then we all have to remember that if a patient manages to lose weight, we have to downsize the dose, because the dose of T4 is partly weight-based. So if the patient comes and has lost 50% of the body weight, you need to decrease T4 by 50%. And then we have this issue down here, which is very, very much run by the patients. They are more and more now using T4 and T3 combination therapy, and some have even started to go back to desiccated swine thyroid. And it's a big discussion, and you can Google it, and you can find ever so many hits, and it's really a challenge for us. So when we are going to tell the patients that it's dangerous, well, I just tell you, we all know that very high doses of thyroid hormones are really dangerous. It is still being used for weight loss in a tablet called Redotex, which is produced in Mexico. And this is a case report that showed a patient who had been in Mexico. She bought the tablets, and she was really in for fast weight loss. So she took 30 of those. And she was put into ER with tachycardia and high T3 concentration that even got up after 2 days to 12 millimoles per liter and suppressed TSH. So is that dangerous? Well, yes, we think so. It seems that these tablets contain 75 micrograms of T3, together with, of course, a little bit of this and a little bit of that, both tranquilizers and agitators. I don't know how they work in combination. But anyway, this lady or this young girl had taken 2,250 micrograms of T4. And patients are not advised, or persons, they do what they want to do. It's sold as effective weight loss pill. It's banned by the FDA. But you know, Trump hasn't managed to set up the wall yet. So at least the Americans can go to Mexico and buy these tablets, and they do, for weight control. So this is not really what is our biggest challenge, at least not in Northern Europe, I think. We are basically rather here with the milder overdosing situations. And is that dangerous? Well, if you look at the classical study by Parler in Lancet in 2001 from Mid-England, where they looked at mortality, all case, and cardiovascular mortality in relation to TSH in a long perspective, a population follow-up study. You can see that patients or persons with suppressed TSH have a much steeper mortality curve from all causes and also from cardiovascular disease. So they die earlier in a population study. Now, what is subclinical hypothyroidism? I actually prefer to call it mild hypothyroidism because it's obviously an abnormal situation. It's a suppressed TSH. T3 and T4 are typically in the high end of the population-based reference interval, but it can be even low or mid-normal. Many of these who have subclinical hypothyroidism have overtreated hypo, as I just mentioned. We've always put it very far down on the list, but basically I think it should be moved upwards because it's becoming more and more an issue. And now when I mentioned that you can have T3 and T4 levels actually very, very normal, this goes with the issue that the population-based reference range, which we all use to tell who is over and who is under, is much broader than our own intra-individual variability, which is quite narrow. So this person with this narrow T4 or T3 can actually have just a median value and be thyrotoxic, right? Because it's outside that person's level. So we are dealing with a lot of complexities that I have to say I find very, very difficult to explain to the patients because, of course, they don't understand this. Now, the reason we can at all diagnose these milder forms of hypothyroidism is by better TSH assays, as I mentioned to start with. Initially, in the 60s, 70s, and early 80s, which I don't know if I could say fortunately or unfortunately, I remember very well, we were absolutely not able to distinguish a hypothyroid patient from a euthyroid based on TSH, sometimes not even by T3 and T4. But now, with the better separation of hypothyroid and normal TSHs, these are normal and these are suppressed, we are very, very precise in assessing a TSH-suppressed situation, and that has improved the situation for the clinician. Patients may not think so because previously they could sort of hide their overdose of thyroid hormone replacement in our inability to disclose it, and now we're telling them, well, you are overdosed. It's like with the hemoglobin A1C and blood glucose discrimination when hemoglobin A1C was introduced. All right, so if we look just at the subclinical or the mild thyroid dysfunctions, is that dangerous? Well, Parler took the British study, he took all levels of TSH. Here you see subclinical hyper also has a much higher mortality in a 7.5-year follow-up. This is a Japanese-Brazilian thyroid study. So from a mortality point of view, at least, it's not anecdotal to take too much. We have to remember, I'm not going into detail about this, Gregorius did that very well this morning, that the thyroid hormone level in the blood is controlled both by the HBT axis, but also by the cellular metabolism guided by the deioninases. So I'll not go further into that. Now, when we look in population studies, for instance, from Denmark, we have a lot of those based on our registries, and hypothyroidism in general, the prevalence is, well, we have overt hypothyroidism in about 2%, mainly among women, few men. But we have, when we look at the subclinical or mild, we have around 3%, which actually overshadows the overt ones if we use the usual criteria. But there you see, about 50% of those are due to iatrogenic T4 or T4 plus T3 replacement. So basically those are almost as much as those with overt hypothyroidism, just to put it a little bit in perspective what we are faced with as clinicians. Again, this is, I took my old slides, we've put it down here, iatrogenic excessive intake of thyroid hormone, as one of the rarer causes of mild hypothyroidism, but I'm sure that it's probably much more prevalent than activating mutation in the TSH receptor when you look at those percentages. So we should consider it more relevant. And now these are the ones we're trying to look at. So what do thyroid hormones do? How do we explain to the patients that even mild hypothyroidism is not a very good thing for them? Because, well, I feel a lot better, that's what they say. I feel a lot better, so you cannot say anything that will make me think differently. Well, thyroid hormones raise basal metabolic rate, we all know that, and they are catabolic, and I have never really understood why patients want to overuse a catabolic hormone, honestly. It accelerates bone turnover, it accelerates energy expenditure with loss of protein, vitamin stores, and so on and so forth. I'll come back to some of the studies that have been done to demonstrate what it means clinically. It does induce weight loss, and basically it appears that that's the important thing for patients. In some of the studies that you also mentioned this morning, the studies didn't demonstrate actually, when they had T4, T3, that the patients felt better when you use questionnaires, but they were so happy with their weight loss, right? It induces muscle loss, which I can show you, and it accelerates heart rate. So now I'll go through these more specifically, but of course not in too much depth for time reason. Now, in 2006, the first systematic selection and analysis of 21 studies on osteoporosis and hypothyroidism, mild forms, were done, and it was sort of median how much was shown, but it was concluded that measurement of bone mineral density was recommended, at least in postmenopausal women with differentiated thyroid cancer starting suppressive therapy. That's more than 10 years ago. Now, another meta-analysis, which was even older, showed that mild hypothyroidism, when you treated subclinical hypothyroidism by radioactive iodine, this was a collection of several studies, then the bone loss was reversed, but only in postmenopausal women. Same conclusion as the previous one. Now, we did a study, a prospective study on hypothyroid premenopausal women and found basically low bone mineral density in all the premenopausal women, or most of them, and they reverted after treatment with antithyroid drugs, but went up again with age with their BMC, BMD, which was basically also to be expected. But we did find lower BMD. And now, finally, we have some new meta-analyses and systematic reviews who are from 14, 15, and 17. And there you can see that the clinical consequences of these, when we put all these studies together, they do have, as a mean, decreased bone mineral density, and not only the surrogate marker BMD, but they do have increased fracture risk, which is, of course, a hard endpoint when you're speaking about bones. So this is particularly prominent in postmenopausal women, and it also seems to be the case on patients who are on suppressive therapy. So we're not only talking about endogenous hypothyroidism, but on iatrogenic, and they do not seem to be different in the term of risk. So it's reversible. So if we can just persuade the patient to go back to normal TSH, we can actually revert the risk of fractures. It's still, if it's permanent, more risky in postmenopausal women, probably because there are more than one factor which is deleterious for the bones. And therefore, you can see the risk for osteoporosis and fractures in iatrogenic hypothyroidism is more than anecdotal, right? Okay, then we go to the other situation that can be dangerous, a heart. This is another case. Now this doesn't work anymore, but I can still change, but I cannot point. Okay, never mind. You can read it, I suppose. This is a woman with newly diagnosed atrial fibrillation, postmenopausal woman. You can see she was not overweight, 60 kilos, height 170 centimeters. She was on T4 replacement for autoimmune hypothyroidism and was getting 100 micrograms. Do you have a better touch than me? No. Okay. All right. So she had suppressed TSH, but normal peripheral hormones. So what diagnosis does she have, and how do you want to treat her? Well, she has iatrogenic subclinical hypothyroidism, so the 100 micrograms were too much. She had the atrial fibrillation. It was not very difficult to persuade her to reduce T4, of course. But I have had patients who have been on T4, T3 combination and claiming they were feeling so good that they didn't want to reduce, not even with atrial fibrillation, which is strange. So we are really dealing with a subset of patients. And when you look at the heart and the risk factors, what can it do? I mean, it's been a clinical observation over ages that reduced or suppressed TSH is associated with a higher risk of atrial fibrillation, and it's about 5 times. We have, this is from American Heart, we have a rather recent Danish investigation showing the same. And again, this increased mortality risk. So the endogenous low TSH is not concerning heart, completely asymptomatic. This study was in women aged less than 65 years. And so these studies now start to indicate that we're not only going to focus on postmenopausal women when we're talking about the risk factors of bones and heart and so on, but women also at all ages, and certainly also males, but there are, as you know, not so many males as females. Ah, wonderful. And then I use this for, yeah, okay. All right. This is also a classical study by, where the first author is Ox, but it's from Nicholas Redondi, and he is responsible for many of the studies I'm showing you because they have this large cohort And they could find cardiovascular mortality with a relative risk increase to 1.21 in their large cohort, and even for this is for heart disease, it's 1.12 for mortality, sorry. So they could only say that it was a modest increased risk, and the quality of the studies was not really very high. But they have then, now it's another first author, but it's still Nicholas Rodondi who is behind this. A very recent one, not on paper yet, but pre-print, they found that only subclinical hypothyroidism has an increased risk of atrial fibrillation of almost 1.7. It's not double, but it's a lot. And for cardiac events, 1.21. So again, it's not anecdotal, it's real. Now, the patients claim that they feel so much better when they are overdosed. I try to explain to them that so does the initiation of short terms of amphetamine and similar, or epinephrines or whatever, because they have this speed effect on the brain. But if you look at what's out there in the literature, the evidence for an association of mild hypothyroidism and mental health is poor. Population studies have not been able to give anything, but a very recent study again, 2016, now is Reben, but it's still Nicholas Rodondi who is behind this, that it seems that subclinical hypothyroidism might be associated with an elevated risk for dementia. So there might be something about it, but the studies on quality of life have not been very convincing, not even in the prospective ones. Now, what about the muscle mass and the exercise capacity? One thing is atrial fibrillation and cardiac events, but the other one is, now if you don't get that, how then? Well, we did actually a study that was published in Clinendo in 1991. Unfortunately, not much focus has been on it because we were focusing in the publication on the fat mass and serum leptin. So the muscles were hidden basically in this figure. So what you see here actually is that the hypothyroid patients at baseline had a much lower lean mass than did weight matched controls. BMI matched controls. And they reverted to normal. But the unfortunate thing about weight loss and hypothyroidism is that they lose more muscle mass and bone mass than they do fat. And when they recover all the different sub-compartments, but the recovery is more generous with the fat, and both muscle and bone is really not recovered that rapidly as is fat mass. So even this loss doesn't really come back to normal. So it means, at least for me as a clinician, I know very well that the patients always complain of fatigue and muscle insufficiency. I mean, even initially strong young men cannot cope with the physical activity that they usually did. And now, fortunately, a study has last year been published in Endocrine where Kaminsky and, et al. Where they investigated 44 people with subclinical hypothyroidism. We're not talking about subclinical, and made them use thyroid during this prospective study. And they looked at the exercise duration and it's called metabolic equivalent and the heart rate. And then they did also cardiac MR, which I will show you in a moment. And you can see their exercise capacity was poorer. All right, and if you look at their cardiac function. This is done by MR. You can see that they had much poorer cardiac index, which means poorer cardiac function. So they couldn't exercise for such a long time, and what they did exercise was poorer. Okay, so now we are getting more and more evidence, actually, for this mild hypothyroid state being dangerous. Of course, people don't die on day one or even after a year, but it is not really a very good idea. The prevalence is rather high, probably higher than we've thought, and it almost amounts to as many people as we see with overt hypothyroidism. We don't know, of course, if we do something early, which means in terms of the iatrogenic situation, if we can persuade the patients to reduce the dose rapidly, we do not know how much that means in prevention of all these disasters, because obviously there are no appropriately powered prospective double-blinded studies. It's very difficult to do. And it seems that TSH values sort of associate with the outcomes. They're dose dependent. So those that are completely suppressed have much more damage in all those outcomes than are those that are slightly suppressed. And what's very important as well, there is no difference in the adverse health outcome between endogenous and exogenous subclinical hypothyroidism. So we have to treat them completely in the same fashion as we do patients who have a hot adenoma with mild hypothyroidism. So we are facing issues with the patients who do not believe all these studies, and we're facing issues in trying to get the information out. Now we're getting more and more valid evidence. So thank you for your attention.
Thank you very much, Professor Rasmussen. We may have time for one or two questions, please.
It appears that the talk was extremely clear, and thank you very much, Professor Rasmussen.
And